Hi everyone, this is Neel Raithatha, consultant audiologist and director of ClearX. Thank you for joining me in my latest video using the iCLEARscope endoscope. And this is the left ear of the patient of whose video I uploaded yesterday, where they've been struggling to hear for 6 years. And in this ear, they've got this dry, crusted skin, and it's really adhered, really deep in the osseous, so the bony part of the ear canal. You can see it's kind of solidified. Now, I did ask the patient whether they used a Q-tips or a cotton bud, as we reference it in the UK, but they said no. And sometimes these procedures are a bit more tricky because we're having to peel off the canal wall, and that might not sound a great big deal, and obviously you're looking at a really magnified view of the ear here, but the bony part of the ear canal is extremely sensitive, and I've previously compared it to your shin bone. So if you knock your shin accidentally against the side of a chair or door, it's extremely acute pain. So be really careful. And so I try to avoid using a correct, for example. Now, a correct would have been, if it was on the more lateral, so more near the entrance or superficial, a correct would have been pretty good. It's not to say that I'm adverse to using a correct, but I'll try and remove this initially using suction, because we're in this difficult region. And what made this a bit more challenging is that this patient's ear canal is extremely narrow, the entrance. Once you enter the ear, it's quite a normal size. And I've just put some drops in here, and you're going to get some blurring. And when you've got a narrow ears and you put oil in, you initially get that. So I'm just, first of all, suctioning excess oil so the blurriness goes. But you will see this just softens the edges just enough so I can start lifting off the canal wall. So these are the procedures that I really enjoy doing, because it requires a lot of patience, but it's kind of what I deem more technically challenging. It may not be the most exciting to watch, but these are the tricky ones. And for this, you need high level magnification. So if you're using standard method of visualization, i.e. head loops, you're going to really struggle with this, because you need to be worked so precisely against the ear canal wall. So we're just lifting this posteriorly. You can see that skin, it's starting to peel away, and the eardrum is slowly beginning to reveal itself. But once I remove this plug, there is some dead skin on the eardrum, which I decided to peel today because the patient, similarly to their right ear, has been struggling to hear from this ear for many years. And so I just wanted to give him a clean start. And also, some of the residual dead skin on the eardrum was coating the umbo region, which I'll explain in more detail as the video continues. And essentially, the umbo region of the eardrum, which is the centre part, is what I call the bullseye. It's where the hammer bone, the first bone in the middle ear, also known as the malleus, where it connects in the centre. So the umbo is the part of the hammer bone that connects to the centre of the eardrum. But the umbo, the centre of the eardrum, is also the progenitor site of skin cells. So the skin that lines the eardrum, the outer layer of the eardrum, should I say, and the inner two-thirds of the ear canal, the bony part. So remember, the outer part of the ear canal, the outer layer is made up of cartilage. That's got 3 layers of skin: the epidermis, dermis, and subcutaneous layer, or hypodermis. But the inner two-thirds of the ear canal, it's only got the outer layer skin, the epidermis, and these skin cells all originate and are secreted, if you like, from the centre of the eardrum. And then they radially migrate across the eardrum and then slowly towards the entrance of the ear canal. So what I mean by radially, if you imagine you've got a little puddle or pond and you drop a stone in the centre, you get those ripple effects coming from the centre outwards. So these skin cells migrate radially from the centre of the eardrum, and it forms a layer of skin. Remember, the epidermis layer of skin is actually a dead layer of skin. It's keratinous. So dead skin cells contain keratin, which is a protein, also found in our hair strands and fingernails. And the skin in the ear has evolved to move sideways like a conveyor belt. Otherwise, once the skin sheds, if it's not moving sideways, it's just going to flake away in the ear canal, and everyone's ears will be full of dead skin, which will make me very busy. But it's not going to be good for, and hence I think it's a evolutionary benefit. Otherwise, if your ears are blocked, you're adverse to any danger around you because you can't hear. So I could have used forceps, but there's very little space. And again, when you're seeing on the screen, it looks huge, but the left-hand side of the ear canal, so the anterior canal wall near to the eardrum, is quite pronounced. And getting forceps there, it's not to say that's not possible, but there's very little wriggle room. So once I open the jaws, because obviously to grasp onto this, I'll have to open the jaws. Either side of the jaws will become in close contact with the bony part of the ear canal. So I've decided to continue with suction at the moment. And also getting the forceps in would have been a bit of a challenge because the entrance is extremely narrow. And I'm using, this is the patient's left ear, I'm using the right-hand side of the endoscope to push against the first bend on the left-hand side, which is just on screen at the moment here, to widen it. Using it like a crowbar, and then I can insert my instrument. So the eardrum is visible, but you can see the skin, it's just lining. Let's just get it out for the patient because I've been suffering enough. And going back to the umbo region, so there's a lot of skin in the umbo region, which can prevent new skin that's being secreted from radially migrating. So I want to clear that as much as possible, so it allows the next layer of skin to begin to migrate as it should be. So you can see the migration tail of this part of skin at the top of the ear canal. So this skin at the top of the ear canal, you can see it's going all the way to the middle of the eardrum. So that's one pathway of skin. And I'm peeling down. So the skin formed at the center of the eardrum in this region, it's then radially migrating up towards 12 o'clock on the eardrum. So the eardrum is slightly tilted here, it's the way we position the patient, but this is 12 o'clock if the patient was sat upright. It's good as skin is migrating upwards towards the top of the ear canal, and that skin will continue to migrate, should continue to migrate towards the entrance, but this skin is no longer migrating, it's just stuck there. Possibly because the umbo region is blocked, so it's kind of almost a tug of war, it's pulling it back from fully migrating. So again, although it looks to the left-hand side of the ear canal, this is the top part of the eardrum. So I'm just trying to peel that down. And you can see that flap of skin in the centre of the eardrum that's just going back. And it is very tricky because there's very minimal space in there. I think I'm using the 17 gauge at the moment. And I was exhausted afterwards because I was putting so much pressure, peeling it. It just didn't want to come away. And I've put some drops in already. You can see the suction tip is very, very close to the left-hand side of the ear canal there. I managed to get the majority away. And as I'm peeling down, I've got to be careful. I've got to be in full control because it's very easy for the side of the suction tip to make contact with the eardrum. Now, what's really, really helped with these procedures are the new Rise suction tips that I've developed. So what I've done with those, not only have I got different gauge sizes, so in the UK, and I've just emailed one of our specialists about it today because they were just asking why I've got all these gauge sizes. I was completely oblivious. I knew all these different gauge sizes existed, but I never knew they were used for microsuction. And that's because in the UK, we just taught certain things. The 14 gauge, which is your standard Zollner, and then you attach a fine end to the tip. And I didn't even know, like other parts of the world, you can get a separate handle and you attach the gauge size of use. So when you attach a fine end to the end of a Zollner, you increase the length. But with the Rise suction tips, you've got a separate handle and you've got a full range of gauge sizes, gauge sizes. I'm getting confused now. And I'm using the 17 gauge as my fine end, but we've also got a 16 gauge, which is really, really useful. The biggest risk when you perform microsuction is noise exposure. So if you can select the right suction tip and not just be limited to the 14 gauge and the 18 gauge, it's really going to help you practice. In fact, today I had a patient who suffers from debilitated tinnitus, so I couldn't perform microsuction. Well, we avoided it wherever possible. I had no choice in the end because there was some wax meat on the drum. But you can see I've just cut that piece of skin away. I'm really happy with that, so I hope you guys are too. Take care, keep well, and speak soon. Bye.